My target today is to speak on recent advances in the management of pulmonary thromboembolism. Now, as we know that pulmonary thromboembolism happens to be the third most common disease producing the current death in the hospitalized patients. So it goes without any emphasis that it has to be recognized properly and treated appropriately. Worldwide, almost like close to 3 million deaths are reported annually with this kind of a syndrome. And to actually dictate the kind of appropriate treatment for the pulmonary thromboembolism, it needs to be actually divided clinically into three groups. One is the minor, where we find the mortality is the least. However, this seems to be the most common presentation of pulmonary thromboembolism. Now we also have the submassive pulmonary thromboembolism, which are almost 40% of the presentations of thromboembolism, and it has got an intermediate type of prognosis. However, if you look at the mortality in this slide, the mortality varies anywhere between 3 to 25%. One may wonder why there is such a gap in the mortality between 3 to 25% when it's in the submassive pulmonary embolism. We'll be understanding this in the subsequent slides. Suffice to say that massive pulmonary embolism happens to be the most dreaded one, with a mortality of more than 25% in the hospitalized patients, and this is the least common presentation that we come across in the hospitalized patients. Now, the European Society of Cardiology has clinically divided based upon the presence of hypotension. When a person comes with pulmonary thromboembolism, it happens to be a kind of cardiogenic, a kind of a hypotension or a cardiac collapse, that's the one where we classify the patient as having massive pulmonary embolism. And the intermediate one who do not have any initial presentation of hypotension, however, they have two other factors, that is right ventricular enlargement, right ventricular dysfunction, and also cardiac laboratory biomarkers elevation. Now, the low risk is the one which don't fit in either of these two parameters, and they have the excellent prognosis. They need to be treated only with antithrombotic treatment. The very important thing that to be noted about intermediate risk group is that is not one uniform spectrum. In fact, it involves two different kinds of populations, wherein one who has both the parameters like elevation of cardiac biomarkers and also right ventricular enlargement or dysfunction, another one who has either of them. So depending upon this intermediate high or low risk, the treatment also is dictated accordingly. Now, at the low risk group, we know all of us that the treatment is only kind of antithrombotic treatment, and we have variety of these treatment regimens that are available. I don't have to go in the details, but it is no controversy about it. Now, the most important thing that we need to actually know is what happens in this intermediate type of risk group who have got two different kind of presentations, one with right ventricular dilatation and also right ventricular dysfunction, also a cardiac biomarkers elevation. The right ventricular dilatation is not without any kind of risk. In fact, this is the one thing which we need to recognize in the hospitalized patients, because this is the one which really dictates whether they require a thrombolytic therapy or not. And therefore, based upon this factor, we need to actually go ahead. Also, it is known those patients who have got right ventricular dilatation when they are present with without hypotension, but they have right ventricular dilatation and cardiac biomarkers elevation, these are the ones who have a poor prognosis. In fact, 10% of them actually progress into shock in the hospital, and 5% of them may actually succumb to this. So therefore, it's very important to recognize this important factor that we in those patients who present with pulmonary thromboembolism. Apart from that, it's also known that those patients who have residual right ventricular dysfunction or pulmonary thromboembolism of the treatment, they are likely to have 8 times more likely to have recurrent VTE and also 4 times increased mortality. Besides this, those patients have inadequate reduction in the pulmonary arterial pressures following antithrombolytic therapy or a thrombolytic therapy, then have a residual clinical syndrome of the dyspnea exertion and persistent elevated pressures for 6 months. So, in order to know whether the intermediate group of patients who are present with PTE, whether they are going to be benefited with thrombolytic therapy, PTOS study has been conducted, which has actually randomized the patients into a tenecteplase or a regular treatment with antithrombotic with heparins. So the outcomes were that thrombolytic therapy was superior. It had produced a mortal reduction almost like 47%, alas, but with what you call a price of increase a systemic bleeding with significant bleeding, and also with increase in the intercerebral bleeding. This is where the problem starts. When we trying to give this kind of class of patients the thrombolytic therapy to improve the outcomes and reduction in the mortality, the increased tendency to bleed intracerebrally or systemically is the one which really requires to be tackled. So, in order to reduce the systemic kind of bleeding, and especially intracerebral bleeding, various measures or various catheter-mediated therapy has been into development, and they have given initial trials have shown a very rewarding outcomes with reduction in the bleedings, and as well as a quick what we call thrombolysis with reduced amount of thrombolytic therapy that's been given to them. So with reduced amount of thrombolytic agent delivered locally with catheters, the increased what we call outcomes have been noted. So based upon this encouragement, various catheter-directed therapy has been into development, which involves a thrombus fragmentation, a thrombic aspiration, or intrathrombus lytic administration using a kind of ultrasound, or for the matter, even the rheolytic therapy as well. So a simple pigtail, which has been used in some of the trials, where the pigtail is rotated across the thrombus, fragmenting the thrombus, and locally delivering half the dose of lytic therapy, actually enhances the clot lysis much more rapidly, and also with less amount of systemic bleeding. It also may be a balloon, simple balloon, which can be used to fragment the thrombus, and thereby enabling quick what we call thrombolysis with half the amount of thrombolytic agent. Also, we have newer technology where we have clear by catheter, which delivers locally when it's inflated into the thrombus a kind of timed release of anti-thrombotic agent or a lytic agent. A simple what's called aspiration also sometimes does a wonder. And we have also the trellis device, where we have two balloons which actually inflate across the thrombus, and the lytic agent is delivered in between the two balloons, and also the catheter in between two balloons actually oscillates at high speed, causing a kind of churning and then disfragmenting of the clot, and then also lysing the clot very, very effectively. And this kind of therapies have been, there's no randomized trial for these kind of therapies. However, the catheter-directed therapy for the acute PE, the perfect multicenter trial, has shown a very rewarding successful rates of outcomes, with almost like in high-risk patients, 85% clinical success rate, and in those patients intermediate risk with about 97% success rate with very limited complications. The only black box warning was for the kind of therapy that was used, that is rheolytic therapy, that angiojet. That angiojet was the one which produced majority complications, but for this particular catheter-based therapy, rest of all the things did not have any kind of major complications that were involved. And by and large, the FDA recently has actually approved usage of EkoSonic, that's ultrasound machine, ultrasound delivery. The ultrasound is a low energy, high frequency ultrasound. When it's actually is given to a thrombus, the fibrin which is in the thrombus gets depolymerized, enabling the clot lysis to penetrate much more easily, and less amount of clot lytic therapy can be used to lyse the clot. So this is how usually the catheter is placed in the area of our thrombus, which is present in the pulmonary arteries, and it's delivered along with the lytic therapy. And then such kind of therapy is backed by two kind of studies. One is Seattle 2 study, which has shown that is single arm study, both high risk and as well as intermediate risk group of patients were studied with a kind of very rewarding kind of results, with dynamic diminishing of right ventricular pressure as well. And then we have also a randomized trial, Ultima trial. Unfortunately, the number of patients are very low on this, but what is important is that within 24 hours, the diminishing of LV-RV ratio. The RV-LV ratio normally is 0.7, and when it exceeds 1.5, it indicates very bad prognosis. Even in those patients where 1.5 ratio was the RV-LV, it did show a rapid decrease in the RV dimensions, thereby translating into better outcomes in the next 1 year. So, to conclude, the recent advances for in the form of local delivery of thrombolytic therapy into the thrombus, and then this is rewarded what we call a decreased amount of complications, especially the systemic bleeding. And the advantage is that the rapid initiation, a low dose adjunctive thrombolytic therapy, and it is very efficacious in dealing with the thrombus. Limitations are, it's a long durational procedure. It usually involves almost like 15 hours in the case of especially the ultrasound therapy. It's expensive. It needs a lot of what we call learning curve, not easily available anywhere. A word around on IVC filters. The IVC filters, the both PREPIC study with the permanent placement and then PREPIC 2 trial, which showed a retrieval kind of IVC filters, have shown no role in the case of pulmonary thromboembolism because they neither increase the mortality, nor they have actually decreased the occurrence of VTE, nor they decrease what we call the fatal outcomes. Therefore, there are no role unless until a thrombolytic therapy or a antithrombotic therapy is contraindicated. So we all know the regimen that we follow. All patients with provoked, then 3 months of therapy post thrombolytic therapy, 3 months of antithrombin therapy. In unprovoked, about 6 to 12 months of the antithrombin therapy with either waterproxafen or any other orally active anticoagulants. And in those patients who have got a kind of existence of thrombotic factors, they require a indefinite therapy after the initial thrombolytic therapy to be followed up. Thank you very much.